Hi, everyone. Welcome to this wonderful seminar presented to you by the SDCFAR and the Developmental Corps. My name is Mary Lewinsky. I'm the Developmental Corps Director. So I have a shorter introduction here for our speaker, Dr. Shirish Balachandra. He grew up in Southern California and completed his undergraduate work at UC Berkeley, studying molecular biology and French literature. After serving as a Peace Corps volunteer in Cameroon, he completed medical training at McGill University in Montreal, followed by family medicine residency at the University of Rochester. He served as chief of the emergency department and TB controller in the Northern Mariana Islands, as associate medical director of a community health center in the Bronx, as public health officer for the UN High Commissioner for Refugees in Rwanda, and then led a global HIV and TB programming for the CDC in Zimbabwe and Cote d'Ivoire. He served as chief medical officer and deputy chief of the DoD's HIV/AIDS prevention program headquartered at Naval Base Point Loma before being removed from federal service along with thousands of other CDC employees in April of this year. Since August, Dr. Balachandra has been working as a primary care provider in the Imperial Valley, catering to a deeply underserved border community. His clinical experience and academic publications reflect a broad range of topics, including HIV, TB, emergency medicine, refugee health, epidemiologic surveillance, and antibiotic resistance. He is passionate about human rights, family, animals, and his beloved LA Dodgers. We won't hold that last point against him. So without further ado, Dr. Balachandra, go right ahead, share your slides.
Thank you so very much. I did not realize that you were going to do quite such a thorough introduction. My deep appreciation to all of you. It's a real pleasure and a sincere honor to be here. Let me just make sure that I am sharing my slides appropriately. Are we good? Here we go. Are we okay there?
Actually, we don't see the presentation mode yet.
Okay.
Maybe it might delay because it took a second to actually even show this, but right now we see it as if you're looking at it in the program.
Got it. How about...
There we go.
Yeah?
Yeah.
Wonderful. All right. Well, thank you so much. Thank you kindly for the introduction, Mary. I really appreciate it, and thank you all for joining us today. I don't need to describe now how I got here and why I got here, but the content of this presentation will be focused on my work with PEPFAR from 2014 to 2024. And just for completeness, my credentials are through the American Board of Family Medicine and the American Association of HIV Medicine. So rather than waiting until the end, my preference is to acknowledge some very important folks right up front. Nicola Willis is the executive director of Jindiri, which is a Zimbabwean NGO right at the center of this story. She's an extremely dear friend and a bona fide inspiration to everyone she touches. It'll be obvious why I must also shout out the Technical University Hospital in Munich, life-saving dedication, generosity, and expertise. Newlands Clinic is the most advanced referral center for HIV care in Zimbabwe, staffed with some of the most selfless and skilled clinicians I've ever met. Brad Hale and Elliot Razies are among my most respected mentors and have supported me for years, but especially during the Munich portion of this presentation. Zimbabwe's Ministry of Health and Childcare is home to some of the most dedicated, astute, and inspiring public health leaders I've ever met. They shaped my professional career and played a critical role through the events in Munich last year. Finally, my professional family at CDC, at what was USAID, and at what was the Office of the Global AIDS Coordinator. That moniker is now out of date. But I will say that what we accomplished together saved and improved hundreds of millions of lives. And for that, I think we should always be proud. So, as the title suggests, my intention with this presentation was to go from macro to micro. I intend to very briefly introduce you all to PEPFAR's approach and impact on global HIV, and then to zoom in from the global to the country of Zimbabwe and its HIV trajectory, then to zoom in further into Jandiri as an organization and its work in Zimbabwe, and finally to zoom in on the story of one very special person. I recognize that there are a fair number of acronyms in here in the presentation. I will try to make sure to clarify them. But by all means, if there are things that I accidentally slip over, but you could put them in the chat and I'll try and catch up later. But here's one right here. CAYPL-HIV is children and young people living with HIV. So let's get started with the global. PEPFAR is the President's Emergency Plan for AIDS Relief, started by President George W. Bush in 2003. I would encourage you all to read about it because I firmly believe that it represents the pinnacle of U.S. government potential, rigorously using data to save lives in an extraordinarily efficient manner. Ambassador Debbie Burks was the Global AIDS Coordinator in charge of PEPFAR from 2014 to 2020, and the program centered around the UNAIDS 90-90-90 targets. So I'll explain what that means. The first pillar is 90% of persons living with HIV in a given country should know their status. So that relates to adequate testing and case finding. 90% of those known to have HIV should be on treatment. So the second pillar is access to antiretroviral therapy, or ART. 90% of those on treatment should be virally suppressed. So the third pillar speaks to adherence to therapy, retention and care, as well as laboratory infrastructure for monitoring. In 2021, those targets got higher, and 90-90-90 became 95-95-95. And in 2023, PEPFAR celebrated its 20th anniversary, and this was on this slide. What you see here is the official fact sheet outlining its achievements and global impact. In my humble opinion, the numbers are simply breathtaking. More than 20 million individuals got access to and stayed on ART. 5.5 million babies born without HIV, and more than 32 million voluntary medical male circumcisions were performed. I'll digress just for a moment about VMMC, or voluntary medical male circumcision, because it's an illustrative example of data-driven decision-making. And since some people apparently don't know how VMMC works in HIV prevention, the graphic on the left is about 10 years old and illustrates the inverse relationship between HIV prevalence and medical male circumcision prevalence. This should make rather obvious the important role VMMC can play in reducing HIV transmission. But I'll elaborate a little further. In 2016, in Zimbabwe, the national HIV prevalence for adults was around 14 to 15%. And through PEPFAR, CDC partnered with the Ministry of Health and Child Care to carry out a landmark national survey known as ZIMPHIA, the Zimbabwe Population-Based HIV Impact Assessment. Data from this survey illustrated that at that time, out of all the people living with HIV in the country, only around 63% were on ART. So you can surmise, therefore, that heterosexual transmission of the virus was still fairly widespread. And in this setting, the NNP, or number of VMMCs needed to prevent one HIV transmission, was only 8 VMMCs to prevent an incident HIV infection. The prevention impact, therefore, of tens of millions of VMMCs in Eastern and Southern Africa is absolutely astonishing. This example highlights several critical keys to PEPFAR's remarkable success. Funding sophisticated modeling, which is how we got to that NNP number. triangulating robust program and survey data, and then making difficult prioritization decisions based on that objective information. Much of PEPFAR's genius, and I will concede, much of the frustration it invoked, was the revolution of monitoring and evaluation, or M&E. In particular, this concept of geolocalization. The graphics on this and the next few slides come from annual review meeting presentations that PEPFAR veterans will recognize with pride. In this slide, we see how the PEPFAR Uganda team illustrated the distribution of people living with HIV across the districts of the country, known as subnational units. The first step is to identify districts with higher and lower disease burden for the purpose of prioritization. So, for example, if we had $100 million to spend in a given country in a given year, it simply doesn't make epidemiologic sense to divide that budget equally across districts because the HIV burden was not equally distributed, nor were the needs of the population. The next step was to look at treatment coverage, defined as the number of individuals on ART divided by the PLHIV in a given area. A district with heavy epidemiologic burden, like those shaded darker brown here, might actually be doing very well with initiating and maintaining patients on therapy, indicated by a mostly green pie chart. Pie charts that were mostly blue suggested greater urgency because given the higher percentage of individuals that were not on treatment. So thus began the process of confronting variables which may be trending in opposite directions. Next, we analyzed the site level. Sites in PEPFAR were clinics or hospitals providing HIV treatment. Akin to my previous point about districts, the logic was as exemplified by this graphic from Kenya, if you have dozens of facilities, each managing small volumes of HIV patients, you'd be hard-pressed to justify providing the same intensity of mentorship and staffing support that you provide to facilities on the right side of the graph, each of which was managing 3,000 to 5,000 HIV patients each. And this is important because site-level support was a linchpin of PEPFAR's theory of change. At those clinical sites, the program not only provided commodities like HIV test kits and medicine, but also human resources for service delivery, for monitoring and evaluation, and patient support like navigators and counselors, and technical assistance for clinical providers, ensuring that patients received high-quality, evidence-based care supported by the national guidelines, which were in turn aligned with WHO. So one size does not fit all. Finally, we went to the level of subpopulation disaggregation. This became very important because a country might be approaching its 95 targets at the aggregated national level, but still be falling way behind with certain demographic groups. In this table from Uganda, you'll see what was a very common pattern across countries. Very high treatment coverage, illustrated in green and dark green, among women of childbearing ages, thereby the most likely to access the health system, and generally poorer coverage among their male counterparts, and really troubling gaps among children. So if adults significantly outnumber children, and women significantly outnumber men, you can see how aggregated results might mask very serious programmatic gaps. Those of us in the trenches often felt like PEPFAR leadership was diabolical when it came to moving goalposts, going from 90-90-90 to 95-95-95. And then that wasn't good enough to reach those targets at the aggregated level. We needed to reach them for each critical sex band. But I say diabolical with my tongue firmly in cheek. The truth is that this is precisely the kind of rigor required to stamp out viral transmission. And it was this kind of data analysis which led the program to double down on innovative case-finding strategies to reach men, children, and adolescents. Another critical focus of the PEPFAR program was serving key populations. In the global HIV world, KP is an umbrella term that includes men who have sex with men, trans and gender diverse individuals, sex workers, and people who inject drugs. As you can well imagine, the transmission dynamics are often very different in these subpopulations, and programmatic gaps often persist long after they've been closed in the general population. These images from the Global Fund, one of PEPFAR's closest collaborators over the years, and whether we're talking about sex workers in northern India, men who have sex with men in Tanzania, or people who inject drugs in Moldova, they all face significant political, legal, and microbial threats to their survival. Subpopulation disaggregation allowed PEPFAR programs to highlight these challenges and try and address them from two important principles. Healthcare is a human right, and transmission anywhere is transmission everywhere. So the point of these few slides in this section really was to give a little, a cursory overview of how PEPFAR worked, and frankly, for me to try and pay homage to an unprecedented humanitarian and public health achievement. If you're interested in this, I would strongly urge you to take a look at the report that I've got listed in my reference slide at the end from the Bush Institute. It came out in 2022 and really articulates the methodology of the approach and highlights some of the impact much more thoroughly than I did here. So let's zoom from the globe into the country of Zimbabwe. For the 5 years that we lived and worked there, it was a nation of about 13 million people, and that number is now over 17 million. In 2000, the HIV prevalence among 15 to 49-year-olds was over 32%. And if that's hard to fathom, you can take a look at this. The life expectancy of a Zimbabwean in 2001 was about 44. These horizontal lines are 5-year age increments. And today we see the life expectancy having once again surpassed 60. And here's the explanatory inverse of the previous graph on life expectancy. This is the trend line of AIDS-related deaths. The dramatic decline in those deaths is thanks to medical and public health expertise, of communities combating stigma, of families and individuals advocating fiercely for equity. Now, over the past 20 plus years, the Zimbabwean and global public health communities partnered to combat this devastation, prioritizing access to life-saving ART for adults, pregnant women, and children, access to HIV testing services, and viral load for monitoring.
There is no audio. There is no audio, Doctor.
Sorry?
Yeah, when you started, there is no audio in the conference. I'm joining. But
Hey, Kim, are you able to mute that one?
It's somebody in the office that it's not one of the guests.
Sorry about that. It was just got a colleague. Is everybody hearing me okay? I think she wasn't able to hear.
Yes,
so.
we can hear you.
Yeah, you sound great.
My apologies. Apologies. Where was I? Right. Over the past 20 plus years, the Zimbabwean and global public health communities partnered to combat this devastation, prioritizing access to life-saving ART for adults, pregnant women, and children, along with access to HIV testing services and viral load for monitoring, and combating stigma and discrimination, most recently with the power of U equals U messaging, or undetectable equals untransmissible. When we examine the 95-95-95 achievement for the country, we do, however, see where work remains to be done, primarily amongst children. If you look at the right side of this graphic, most of the remaining challenge is with the first 95, the blue bars, or knowledge of status, therefore case finding, right? This data shows us that once Zimbabwe identifies children that have HIV, they do a solid job of getting them onto ART. That's exemplified by the second bar, the orange ones there, and reasonably well at maintaining viral suppression, which is the third bar in gray. PMTCT, or prevention of mother-to-child transmission, is a core pillar of epidemic control, as illustrated here. ART coverage among pregnant women living with HIV leads directly to reductions in vertical transmission. It's a central theme for this presentation because much of Jindiri's revolutionary work has been with children and adolescents who were born with HIV, and we're only now confronting the novel landscape of those children having become adults. So appropriately, the next Zoom goes from the country of Zimbabwe to an organization called Jindiri. Jindiri is a Zimbabwean NGO conceived in 2004 to care for children and young people living with HIV. Jindiri in the Shona language is a phrase which means as I am. And the ethos was accept me as I am, as an HIV positive individual. And this was a critical concept in a world where people living with HIV were devalued, ignored, and worse. The organization has remarkably rocketed from its humble origins, cutting adult ARV tablets by hand and packaging them in a garage for children, to developing what WHO, PEPFAR, and the Global Fund all recognize as a gold standard, and that is the CATS model. CATS are community adolescent treatment supporters, and the CATS model is one of intense peer support. Young people living with HIV are trained and mobilized to find and support others, to help caregivers with HIV disclosure for children, to increase HIV testing among siblings and sexual partners, and ultimately to help ensure long-term viral load suppression to survive and thrive. Jindiri is the only organization to have generated randomized control trial data for this kind of an intervention, both in terms of viral load suppression, as well as significant reductions in depression symptoms among its beneficiaries. We got to Zimbabwe in 2015, and my colleagues and I lobbied very hard for PEPFAR to support Jindiri in a major way. And while money isn't everything, this graph illustrates what funding made possible. This organization went from supporting about 2,500 kids to supporting around 60,000 children and adolescents living with HIV across Zimbabwe and then across sub-Saharan Africa. Just note here that there's no implication of green versus yellow. Those were just handy colors to outline national borders and distinguish one country from another. This is funding data illustrating Jindiri's growth over time. If you see the drop-off in the yellow bar trend, that is active beneficiaries in 2023, that represents the abrupt loss of one of Jindiri's major funding sources. When funding transitions are unplanned, poorly coordinated, and poorly communicated, there are very real-world implications for life-saving services. I mention this because this year we have witnessed this administration's handling of the PEPFAR program, which many would classify as a bit of a debacle. I don't have slides to quantify the impact of this management or mismanagement because the data itself is so difficult to obtain as the M&E systems that I described earlier are all being dismantled. We do have some estimates, like the fact that the number of people on treatment worldwide in the PEPFAR program has dropped by approximately 200,000. But to be honest, it's pretty difficult to quantify a mass casualty when the books are being burned. But this is precisely why Jindiri and many other successful local NGOs have worked so hard to not create parallel standalone programs, but rather work together with ministries of health to integrate programming and render it truly sustainable. And that brings us then to Munich. So last year, the International AIDS Society held its biennial conference, the Global HIV Conference, last year known as AIDS 2024, in Munich, Germany. I was there with Dr. Hale, representing the DoD HIV/AIDS prevention program. Nicola was there with the Jindiri team. And rather unexpectedly on day one, I got a phone call from Nick asking me to come quickly. I ran to the other side of the conference center to find one of the Jindiri team members rather unwell. He had arrived a couple of days before from Zimbabwe. He was the team's IT specialist and was a former CATS himself. Over the phone, Nick had told me that he wasn't feeling well, that he wanted to go back to the airport and fly home to Zimbabwe. And she'd asked if I'd come and assess him and try and talk him out of that notion. He was breathing at about 30 breaths a minute and looked pretty ill. I didn't have a stethoscope or any other equipment with me, but I could infer from his thready radial pulse and his overall demeanor that things weren't great. My words to him were, "My friend, I agree we need to get you out of here, but not to the airport, to the hospital." We got the conference medical team to come over eventually and check a blood pressure. It was 90/60, and they immediately called an ambulance. So to recap, this gentleman was 30 years old, born with HIV, served as a CATS with Jindiri until he aged out. And at that point, he applied for and was selected as an IT associate. Having undergone several treatment disruptions over the course of his life, he was now on Zimbabwe's third-line ART regimen, namely dolutegravir, emtricitabine, tenofovir disproxil, and ritonavir-boosted darunavir. He was well controlled on this regimen, as evidenced by an undetectable viral load, and you'll note that his CD4 count was 250 a couple of months before this all happened. Now, as you all may know, individuals perinatally infected with HIV are at risk of developing chronic lung disease in adolescence and thereafter. And this is one of many areas of ongoing research and interest, as this cohort of individuals is the first in history to be navigating the landscape of aging with HIV from birth. In my final slide, with references, I've listed one by my friend Rashida Ferran, who is among the pioneers, together with colleagues in Zimbabwe and South Africa, to explore and document this complex syndrome among Zimbabwe's youth. So upon arrival at the Technical University Hospital of Munich, the patient's blood pressure was 130/60. He was sitting at 88% on 6 liters of oxygen and was getting increasingly distressed. Before long, he was in the ICU and he was intubated. The original report from his CAT scan of the chest read as follows: extensive atypical pneumonic infiltrates bilaterally, predominantly peribronchial in the upper lobes, with additional pneumatoceles consistent with the findings of PJP. Just for fun, I left the laboratory parameters here in the original German terms, so let me quickly just clarify. Got the hemoglobin, procalcitonin, C-reactive protein, the white count, AST and ALT, the bili, the LDH, and an absolute lymphocyte count of 200. The CD4 count was 20, and the viral load was undetectable. He tested positive for influenza B, and a bronchoalveolar lavage was positive for both PJP and CMV. So the patient was treated for both influenza and PJP. He ended up spending nearly 4 months in the hospital. Nicola and I were back and forth constantly during the week of the conference, and she stayed on for much longer. Miraculously, ultimately, he did get extubated. I should mention that the ICU team at the Technical University Hospital had benefited greatly from their vast COVID experience, especially in terms of long-term ventilation of younger patients. Thereafter, the patient benefited from intense rehabilitation from the physiotherapy team. And all along, he received tremendous support from Zimbabwe, from family and friends, from his medical team at Newlands, and leadership at the Ministry of Health. He also received incredible support from the International AIDS Society and their scholarship team because he was attending AIDS 2024 on scholarship. They helped with multiple visa extensions, insurance, and critical logistics. Honestly, it really does take a village. In my humble opinion, the critical clinical message of this story is the unexpected immunosuppression that came not from HIV, but rather from the drug-drug interaction between the inhaled corticosteroids and a protease inhibitor regimen. I don't mean to imply that anyone did anything wrong, far from it. I highlight this simply as a caution that Cushing's syndrome is clearly a risk to be considered as we juggle HIV management alongside chronic lung disease. Remember that he had been virally undetectable and remained so throughout, and initially had a CD4 count of around 250. But that said, he'd slowly developed these Cushingoid features over the course of several months, and this should raise alarm bells for severe immunosuppression in spite of effective management of HIV disease. So here are some take-home points from the clinical case. The first bullet point about adults living with HIV since birth, frankly, it could be an entire presentation by itself. Thanks to organizations like Shindiri, we have an opportunity to care for these people who have survived for decades against all odds. Many people argued that it wasn't even worth trying to treat children with HIV because their survival was all but impossible. But now here we are with the extraordinary honor of helping them navigate having their own children, achieving their own dreams, and living rich and fulfilling lives. The second bullet point is a perennial struggle for those of us who straddle the micro and the macro. Public health is and should be about populations, but those populations are made up of individuals, and the onus is upon us to balance those perspectives. Third bullet point speaks for itself. Whether you're at a conference or anywhere else, be prepared. Maybe bring your stethoscope. And finally, let's not lose hope. Through sincere and meaningful collaboration with partners and communities, we've moved mountains beyond mountains, and we can continue to do so if we remain committed. I made a couple allusions to this before. I would really urge you to check these out. Jindiri's website is here first up front. The report from November 22 from the Bush Institute is the second bullet there, PEPFAR and the Geolocation Revolution. Reference for those who are interested on HIV prevalence and how that relates to the prevalence of medical male circumcision. I am deeply indebted to the National AIDS Council for making available their latest annual update slide presentation to me on Zimbabwe's progress with HIV, and several others here that hopefully will be of interest to you all. But I've come to the end, and I actually have a very special treat for you, the opportunity to shift the focus to where it rightfully belongs, to the patient himself. So I'm going to ask Lucky, joining us all the way from Harare, Zimbabwe, at 10:35 p.m. to switch on his mic and, if possible, his camera. I know he was having some IT difficulties, so I don't know if the camera's working, but say a few words to give his perspective, which is the central perspective here, and to field any questions that you may have. It's my sincere honor to introduce you all to my friend, Luckmore Pamidzai. Lucky, you can take it away.
All right, thank you very much. Unfortunately, I won't be able to switch on my camera. I'm having some technical difficulties with it. So I think just like what you have heard, for years, my HIV has been well controlled through the antiretroviral therapy. and my viral load has remained undetectable, and I lived with the confidence that treatment was working. Yet I learned firsthand that even when HIV is under control, other health challenges can still threaten well-being. So early in my journey, before I even joined Swandiri, I struggled with adherence, which is one of the reasons why I'm now on third line treatment. But later on, when I joined Swandiri in 2016 as a community adolescent treatment supporter in Mount Darren, which is one of the rural districts here in Zimbabwe, I was able to regain consistency and maintain suppression. So the role which was played by the Zandiri model as well as the Newlands Clinic was really pivotal in ensuring that my treatment outcomes improved and remained stable. From my story, it's actually a reminder that viral suppression alone does not guarantee well-being. Commodities and opportunistic infections can still pose significant risk, even in the context of controlled HIV. So I know that here today we have so many clinicians, and this underscores the importance of integrated care models that extend beyond HIV management to encompass the issues of mental health, nutrition, sexual and reproductive health, non-communicable diseases, and the protection against other infections. So the lesson to you is very clear. We need to strengthen our primary healthcare systems so that there is prevention, there is early detection, and there is also integrated treatment, which must be accessible to all patients, including young people, regardless of socioeconomic status. So this actually means that we must have youth-friendly, comprehensive services under one roof. So encompassing HIV treatment, opportunistic infection management, NCD care, and sexual health services. This is really critical to sustain long-term health outcome. So my story also illustrates that HIV can be controlled, but comorbidities must be proactively managed to secure long-term well-being. If we envision to end AIDS by 2030 as a public health threat, this will require more than viral suppression. It will demand resilient health systems, integrated care pathways, and also sustainable financing mechanisms. So as clinicians, you actually play a central role in this transformation by ensuring that care delivery is holistic, stigma-free, and responsive to the realities of young people living with HIV. So talking about now, beyond my usual HIV treatment, the clinicians at Newlands Clinic, they continue to monitor me closely with monthly to 2 monthly reviews, and I'm doing very well, still with an undetectable viral load and a CD4 count which is increasing. So my last CD4 count was 430, and my renal function, FBC, and liver function tests are all within normal ranges. And I'm also being managed for hypothyroidism and copulmonale, and I remain clinically stable. So today I'm feeling hopeful and so empowered because my journey has taught me that health is not defined by HIV alone, but by the strength of integrated care and the resilience it builds. And I'm actually proof that with consistent treatment, holistic support, and compassionate clinicians, us as young people, we can thrive, not just survive. And my confidence in the future is stronger than ever as I carry this optimism forward as both a patient and an advocate. So thank you very much for this opportunity, and I'm so happy that my story will change the way treatment is taking place. So thank you very much, and back to you.
Well, honestly, Lucky, there's nothing I can say to follow that. That is absolutely wonderful. It's so it's miraculous, and it's a testament to, like I said, an entire village's efforts, but most of all you and your family, for perseverance and resilience and hope and ambition. Um, so that is deeply appreciated. But you also make some really important points that I think it's critical for all of us on the clinical side and on the public health programming side to bear in mind. As you said so rightly, we can't be satisfied exclusively chasing a target of viral load suppression, right? Even if we get to whatever benchmark we set for ourselves with an individual or with the population of achieving viral load suppression, we would be very foolish to not look at what else plays into the entirety of that individual and that population's reality, and what might then threaten that viral load suppression tomorrow, and also what else might be going on in spite of that viral load suppression, like what happened in your case. I think that is all we had in mind. So perhaps we can entertain some questions. I think we were rather efficient, which doesn't always happen. We actually have a little bit of time left over here. So perhaps we can open up the floor, but if not, we can also